Priyadarshini, Course Director for Study EBCOG at StudyMEDIC. And in today's video, we are going to see the module Labor and Delivery, and I'm going to talk to you about how do you approach EMQs for the exams. So whenever you take an extended match question, you will have a lead question and followed by the options and you have the scenarios. Most important thing that I follow for EMQs is to apply the cover test, wherein I will be looking at the scenario, picking up what the scenario is asking me to analyze, and then I will get my answer. Once I have the answer, I go back to the options and look at the options and choose the closest option that is applicable. So let's look into the first scenario that we have. So we have Lara, a 26-year-old, second gravida at 29 plus 4 weeks of gestation, presenting to the tertiary care setting complaining of lower abdominal cramps and mild backache for the past 6 hours. So what I understand from this, preterm labor could be a possibility. And where am I? I am in a tertiary care setting, so I have all the necessary arrangements. Next, her previous pregnancy resulted in spontaneous preterm delivery at 32 weeks. Risk factor identified. On examination, vitals are stable, CTG is reactive, speculum closed cervix, no evidence of lycopolling. So there is no PPROM, there is no cervical dilatation. However, she is at a very high risk of having preterm labor. Ultrasound, cervical length is 25 millimeters. Well, we know it is a short cervix, but what is the possibility of going into preterm labor? That is the question that I have in mind. Let's see the scenario again. Dipstick is negative, lab shows WBCs and CRP is normal. She's concerned about going into early labor again. Okay, so here this woman who's got a very high risk factor of going into preterm labor is worried whether she's going into preterm labor or no. So what are we supposed to do? We need to give her an option by which we can predict her possibility of going into labor. Well, when the transvaginal ultrasound is 25 millimeters, the next test that I have in mind is to look at the fetal fibronectin levels. So let me go back to the options and check whether we have fetal fibronectin. Yes, we have option H, which is fetal fibronectin testing. Going into this next scenario, we have Noor, a 30-year-old primey, 24 plus 2 weeks, presenting with regular contractions every 10 minutes for the past 3 hours. Again, primey and possibility of a preterm labor here. She's currently in a rural unit without neonatal intensive care facilities. Well, that's an alarming thing. That means there are no NICU facilities, so she might require transfer out if you have confirmed preterm labor. Let's see. Speculum examination 2 centimeter dilated. That means, yes, you have made the diagnosis of preterm labor. You don't have the facilities. You need to shift her out. Ultrasound is again not available. Transvaginal is not there. So we have an ultrasound which says the fetus is of normal anatomy, adequate fluid, vitals are stable. WBC CRP is normal. The on-call registrar doesn't know what to do. So they are uncertain. So they are asking about the next step. So here we have confirmed the diagnosis of preterm labor. You don't have the facility of NICU. Best is to shift her in utero. So let us see. So we have the option of transfer to tertiary center. Well, that has to be appropriate here. Next one, we have Julia, a 28-year-old, second gravida, 31 plus 3, reporting clear fluid leaking vaginally for the past 5 hours. So we have made a diagnosis of PPROM. There are no contractions. Vitals are normal, speculum showing a fluid in the posterior fornix. So once again, we make our diagnosis. The length is 26 millimeter. The ultrasound is showing normal fetus with oligoamnios. Well, because she's draining the fluid level has gone down. CTG is normal, lab is normal. So you are suspecting PPROM. Well, you have also confirmed PPROM because of all this. So what do you do for her? She's a case of PPROM, but however, she's not in labor. There are no signs of infection. So you provide her expectant management, but you need to start her on antibiotics. So oral erythromycin will be my choice here. Well, looking at the options here, I will go in for option J, which is antibiotics for PPROM. We also have one more option of antibiotics, that is M, which says broad spectrum IV antibiotics and delivery. Well, that will not be appropriate here. Though we choose antibiotics, IV antibiotics is not required, and again, delivery is not required. We just have to wait and watch. Going into the next scenario, we have Daria, a 19-year-old, gravida 1, 27 weeks, presenting with regular contractions for 4 hours. So again, suspicious of preterm labor. Speculum 3 centimeter dilated. So well, we have made the diagnosis of preterm here. False smelling vaginal discharge. So here comes another important key factor. False smelling vaginal discharge, always rule out choriamnitis. She is febrile. Again, high risk factor, heart rate is 102, fetal tachycardia. Maternal fetal tachycardia, febrile, false smelling vaginal discharge, which is more than a clue for making out choriamnitis. Lab CRP is elevated and WBC is also elevated. So you have made the diagnosis of choriamnitis. Then what are you supposed to do? You will have to deliver her. You have to give her antibiotics. So you give her IV antibiotics broad spectrum and deliver her. Next, going into the last scenario, we have Marta, a 32-year-old at 33 plus 1 weeks, complaining of mild uterine tightening for the past 3 hours. So, primary 33 plus 1, just vague tightening, she's telling you. CTG is normal, no cervical change. Transvaginal ultrasound, cervical length is 27 millimeter. Fetal fibronectin test is negative. So, what do we get out of this? That means we have a strong suspicion of preterm labor. However, her possibility of delivering in the next 48 hours is going to be quite less. Fetus is normally grown, amniotic fluid is fine, the CRP, WBC, everything is normal, and of course, there is no history of preterm labor also. So everything seems fine here. So you just offer her expectant management, keep her on a close watch because she can go into preterm labor. However, since fibronectin is negative, you're not going to do anything actively. So going back to the options, let me see. Administering steroids, magnesium sulfate, as of now, not required. Circulate progesterone, again, I'll not think about it. Tocolysis, no, I have not made the diagnosis, so I'm not going to give her anything. Expectant management, well, this seems to be fine because we are not going to do anything. We just keep her under a close follow-up. So these are the answers. So what I have done, I have gone through the scenarios, I have picked up my important clues and I have tried to analyze which is going to be the management option there. I went back to the options and I tried to match with my answer to see if it actually works. Well, this is how you go about with your EMQs. So these are the answers once again. So, what are the key factors that you have to keep in mind? First thing, look at the patient age, look at her status, the clinical presentation of her, what does she come with. Next, look into the lab values. Always try to correlate the lab findings with the clinical scenario and make your diagnosis. So, diagnosis can be made from the history, diagnosis can be made from the lab and the radiological investigations that has been provided to you. Not to forget, you will have to look at the lead statement or the question that is actually pointing out to you. Are you looking into the diagnosis? Are you looking into the management? Are you looking into the investigations? See what exactly is being tested in that particular scenario. Once you get that, you will never go wrong with your answers. So most important points to keep in mind when you're dealing with a case of preterm labor. The preterm labor prophylaxis can either be with vaginal progesterone or cervical cerclage. You can either offer them a progesterone or cerclage when a woman has a history of spontaneous preterm birth, which says up to 34 weeks, or loss of pregnancy from 16 week onwards. And along with that, she also has a TVS with the cervical length is less than 25 millimeters. And remember, this TVS is done between 16 to 24 weeks of gestation. We offer the woman prophylactic vaginal progesterone for a woman who has either a history of spontaneous preterm birth up to 34 weeks of pregnancy or loss from 16 weeks of pregnancy, or she has an ultrasound finding which says the cervical length is less than 25 millimeters, where the scan is done between 16 to 24. So when both the parameters are present, you will offer her either progesterone or cerclage. If either of them are present, you will offer her only vaginal progesterone. Now, when are you going to offer her a woman? For sure, a cervical cerclage. If a woman has a transvaginal ultrasound finding of length less than 25 millimeters, and this is done between 16 to 24 weeks, along with a history of cervical trauma or a PPROM in her previous pregnancy, then you need to offer her cervical cerclage. Now, let's go into the next scenario. We'll follow the same pattern as we did before. So here we have Sarah, a primey, 29 weeks, presenting to the maternity assessment unit with complaints of sudden gush of fluid followed by continuous leaking for the past 4 hours. 29 weeks, leak of fluid, PPROM. She has no fever or uterine contractions. It's a sign that she's not an infection. On examination, she is apyrexia, BP is normal, heart rate is normal, palpation is non-tender uterus cephalic presentation. So all these are ruling out choriamnitis. Speculum examination, clear fluid is seen in the posterior fornix. So you have confirmed a diagnosis of PPROM. CTG is normal. Lab shows CRP is 8, WCC is 9. So again, there is no infection. She has no signs of choriamnitis. Diagnosis of PPROM is made. So what can you do with her? Not in labor, not in infection also, but she has ruptured her membranes. I will give her antibiotics. So the choice will be oral erythromycin for 10 days. Now let us look into the next scenario. We have Fatima, a second gravida at 30 weeks, 2 days. She is arriving to the hospital reporting fluid leakage and occasional mild cramps for 1 day. On initial review, she is afebrile, her uterus is non-tender and fetal movements are present. CTG is normal, blood shows a CRP 10, WCC is 11. Ultrasound shows oligoamnios with a live fetus. Again, PPROM. No signs of infection here. What has been done to her? She's admitted, given oral erythromycin and monitored. On what happens after that? Second day, she's having uterine discomfort, temperature is increasing, CRP is increasing, WBC is also increasing, and fetal heart rate is showing tachycardia. That means what? She has gone into choriamnitis. So infection has set in, we will have to deliver her. Okay, so we'll have to deliver her. Of course, we'll have to give her antibiotics and deliver her. We have to give her intravenous broad spectrum antibiotics and plan for delivery. Next, going into the third scenario, we have Amina. She is a primary gravida who presents with spontaneous rupture of membranes at 30 plus 5. She is clinically stable, no uterine tenderness or fever. BP is 115 over 70 and pulse is 78. She has no uterine contraction. Speculum shows there is amniotic fluid leakage. CTG is reactive. So what is it? We have made the diagnosis of PPROM and clinically she is stable. Labs are fine, CRP and WCC is normal. She has already received dose of oral erythromycin. Fetal growth amniotic fluid index are all normal. Obstetricians plan for corticosteroids, but she is currently stable. So should you give her corticosteroids or should you not give her corticosteroids? Well, 30 plus 5 weeks rupture of membranes, there is a possibility of her delivering. So steroids can be offered to her. Now, looking at the weeks of gestation, what are the key factors you have to keep in mind? Whenever you have a case of preterm or PPROM, think about whether she's going to deliver immediately. Antibiotics for PPROM, and for preterm you'll have to rule out infections, and the role of steroids and magnesium sulfate must always be kept in mind. Now going into scenario 4, we have Leila, primary, presenting a 12-hour history of fluid leakage. Again, PPROM. She is not in labor. Speculum confirms the pulling of amniotic fluid. That means you have made the diagnosis of PPROM. Vitals are stable. CRP-WBC is normal. CTG is also fine. Fetal presentation is cephalic. She has already completed a course of steroids 10 days prior because of a suspected preterm labor. There are no clinical signs of choriamnitis. It means there is no infection. She is not in pain, but she has a PPROM. She has already finished a course of steroids. Pregnancy is 34 weeks and 2 days. So 34 weeks, you better deliver her because she has already ruptured her membranes. Expectant management can be offered up to 34 weeks. Now going into the next scenario, we have Grace. She's a third gravida, G3P1A1 at 28 weeks, presenting with clear vaginal fluid loss for 8 hours. There are no uterine contractions or fever. Speculum examination confirms amniotic fluid pooling. She is hemodynamically stable and CTG is reactive. Fetus is cephalic, there are no signs of infection, and CRP is 7, WBC is 8.5, and then she has not yet received her steroids or antibiotics. So what you have to do for any woman who's coming with PPROM, you will have to offer her steroids. That is mandatory. And along with that, you will have to give her antibiotics because we know antibiotics, oral erythromycin is the choice. Now, what is the role of steroids? What is the role of magnesium sulfate? Steroids and magnesium sulfate are given for women who are at a very high risk of delivering immediately. PPROM, even though the woman is not in labor, there's a very high chance labor can set in immediately, or you will have to induce labor whenever you see that she is going into infection. So all this has to be kept in mind whenever a woman is coming with PPROM. Though not in labor, there's a very high possibility she can deliver early. So let's look into the answers here. So for the first scenario, there were no signs of infection and she was stable. So you give her oral erythromycin. Do not use co-amoxiclav because there's a high risk of developing necrotizing enterocolitis in the baby. Second one, we had Fatima. There was evidence of chorioamnitis, so we'll have to immediately deliver her. What is the role of antibiotics here? Yes, IV antibiotics is definitely needed for her. Next, Amina, she is 30 plus 5. She's stable. There is no infection. So you just give her expectant management with steroids. And next scenario, beyond 34 weeks, however, because of the infection risk, you can plan delivery. And the last one, you just offer her magnesium sulfate for neuroprotection because she is only 28 plus 6 weeks. Okay. So you can offer her magnesium sulfate because of the gestational age. So for pre-prom, what are the key important factors? First one, you will have to look at the gestation and you have to make sure the membranes have ruptured. How can you make out? One is by doing a speculum examination. You will find there is pooling of fluid. Do not do a digital examination unless otherwise the woman is in labor. If it is not sure with a speculum examination, then you have to use your other factors. You are not going to use your nitrogen test. However, you will be using the amnesia test to make sure whether she has ruptured her membranes. Labs, of course, you have to do to rule out infections. The full blood count, CRP, is essential. When any time you find the CRP or the WBC to be increased, then you are the suggestive of chorioamnitis. Antibiotic of choice is going to be oral erythromycin 250 milligram QID for 10 days. You're not going to use comoxiclav here. Steroids from 24 to 33 plus 6 weeks you can give. Neuroprotection is with magnesium sulfate, and tocolysis generally not recommended because again infection risk can be quite high. And suppose if you want to cover the woman with steroids, then yes, tocolysis, if the woman is not in labor, it's not going to help us in any way. Monitoring, you'll have to look at the ultrasound for AFI because she is leaking. You'll have to make sure that some amount of fluid is there for the baby. You have to look at the vitals and fetal heart rate monitoring. Signs of infection can be picked up by looking at the maternal vitals. Delivery timing, you can offer her expectant management till up to 34 weeks. After 34 weeks, you know the chance of infections are quite high and the baby has received steroids, then of course you can plan for delivery. So whenever there is signs of chorioamnitis, there is no point of waiting any further. You'll have to deliver them immediately. So PPROM is nothing but the rupture of membranes before 37 weeks of gestation and before the onset of labor. This is based on the history, based on speculum examination and no digital examination. Investigations, I told, amniotic fluid is leaked. So you'll have to take a swab to rule out infections, CRP, WBCs. Then what are the tests of choice? One is the direct examination of the fluid. If not, you do an insulin-like growth factor binding protein 1 or placental alpha microglobulin 1, which is also called as amnisure. Do not use nitrogen. Drug of choice is oral erythromycin. Next, let us look into some categories of cesarean section. So again, we are going to start with the scenarios here. Now, the first scenario, we have Mrs. Amina Yusuf, who's a 30-year-old second gravida, presenting at 39 plus 3 weeks of gestation in active labor. Now, she has been 6 centimeter dilated for over 4 hours despite strong uterine contractions. So, what do we do here? We have made the diagnosis of a delay in the first stage of labor. And the most common cause is having inadequate contractions. Well, here it is mentioned she's having strong uterine contractions. So there is no uterine inertia here. Her previous birth was vaginal. A continuous CTG monitoring shows a baseline heart rate of 170 with absent variability and recurrent late decelerations. So this CTG is not at all fine. You see the basal heart rate is raised up. So tachycardia, loss of variability and recurrent late decelerations, making it a pathological one. There are no meconium stained liquor and her membranes have ruptured 3 hours ago. Okay, so everything possibility of augmenting the labor has already been done. The membranes have ruptured spontaneously. She's getting adequate contractions and still she is not progressing. So that means you'll have to act here to deliver her. And another important thing, the CTG is not fine. So the baby is giving us signs that it has to be quickly delivered out. And her BP pulse is stable. There is no fever. So infection has been ruled out. Lab investigations, HB is 10.4, normal platelet count. And obviously she's not pushing. We know she's only 6 centimeters. So what are you supposed to do? A registrar is called to review the CTG findings. So let's look into the scenario here. Okay, though she has have a previous normal vaginal delivery, this labor is stuck. Okay, 6 centimeters, 4 hours and not at all progressing. The possibilities here are we can rupture her membranes, but we see it's already ruptured. We can start her on oxytocin augmentations, but you see she's having uterine contraction. So all the possibility or the necessity steps taken to augment labor are already being done. Despite that, there is no progress. So we'll have to review, the whole obstetric review has to be done and we'll have to progress, we'll have to tell her for a cesarean section. Now we'll have to choose which is the right category of cesarean section. This woman is an eligible candidate for category 2 cesarean section. Why? Because there is nothing so actively that we have to crash delivery her, but we'll have to deliver the baby at the quickest time possible. Hence, category 2 will be adequate for her. So let me go back to the options that we have. Yes. So we have category 1, definitely no, there's no immediate threat here. Category 2, yes, definitely I will say. 3, 4, no. Now looking at the other options, it was given as emergency cesarean for uterine rupture, cord prolapse, failed instrumental delivery. No, she's definitely not into that. But again, if you look option J, K and L, again there are different categories that is been there. So look at option K, it says category 2, suspicious CTG, no progress. Well, I will choose category 2 because option K, because it is mentioning category 2, but it's also giving me additional information about the CTG and non-progress of labor. So option K will be most appropriate here. Looking at the next scenario, we have Helen Thomas, who is a 26-year-old primary gravida, and she is brought to the labor ward via ambulance at 38 plus 1 weeks of gestation with sudden severe abdominal pain and a history of previous unscarred uterus. Okay. On assessment, there is vaginal bleeding. Fetal parts are palpated superficially. That means rupture uterus. Whenever sudden severe pain and fetal parts are palpated superficially, you will have to think of rupture. Rupture uterus can also occur in an unscarred uterus. That has to be kept in mind. CTG is showing prolonged fetal bradycardia, 80 beats per minute, absent variability. That means you will have to deliver the baby immediately. Rupture uterus, category 1, cesarean section. BP is 90/60, heart rate is 110. She's pale, distressed. The bloods are showing that HbS dropped from a antenatal of 11.6 to 7.8. So it is a case of rupture uterus and you have to take her for theta. So again, for category 1, immediate threat to life of woman or fetus, yes, she's definitely for category 1. But let me look at other options that I have. I also have emergency cesarean due to uterine rupture, yes. And I also have category 1, placental abruption with fetal bradycardia. And I also have one more category 1 which mentions eclampsia with severe fetal distress. So of all, definitely it is not a case of eclampsia, it's not a case of abruption, so I'm ruling out 2. So I'm left with 2 options. Is it category 1 like option A, or do I go in for option E? E will be most appropriate here because it is clearly mentioning the diagnosis also, which is uterine rupture. So going into the next scenario, we have Samira, a 34-year-old. She's attending the antenatal clinic at 37 plus 6 weeks. Ultrasound is showing breech. She has declined external cephalic version even after counseling. She is not in labor and has no contractions or symptoms. Antenatal history is uneventful. She opts for an elective cesarean section. BP is blood pressure is normal. Hemoglobin, urine analysis, everything is okay. A date for cesarean section is booked at 39 plus 1 weeks. Okay, so this woman is wanting for an elective cesarean section after 39 weeks. Fair enough, because she has a declined external cephalic version. You have to respect her autonomy. So it is definitely a elective cesarean sections are always category 4. So we have option D, which says category 4 elective cesarean section at maternal request. Yes, it is quite opt here. Let us look into the other options. It is saying option G says elective cesarean section for due to complete placenta previa, no. Elective cesarean section for breech and primary gravida, yes. That is again one of the most suitable options here because it's also giving us the diagnosis. So I will go for elective cesarean section for breech and primary gravida. Next one, we have Jane Murray, a 33-year-old second gravida with history of cesarean for failure to progress, presenting at 40 plus 4 weeks. So she is already post-dated. She reports irregular mild contractions and a show. On examination, she is 2 centimeter dilated, membranes are intact with cephalic presentation. CTG is reactive with baseline of 140. She is not an established labor and a decision is made to schedule a cesarean the next day as she wishes to avoid a trial of labor after cesarean. Okay, so because of previous cesarean, post-dated pregnancy, and she is not willing for a TOLAC, means she's not willing for a trial, so you offer her a elective cesarean section. So what category is this going to be? Is this category 3 or is this category 4? Now category 4 means it is always an elective cesarean section. Category 3 means the woman is in established labor, say a very late and early labor, but she is not progressing so far, and you know that okay, you'll have to do a cesarean section. Okay, now here if you see what are the options we have, we will go back. So, category 3, we have option C, which says elective delivery, early delivery needed. No, there's no compromise. And category 4 means it is an elective CS at maternal request. Other options, elective CS due to complete placenta previa, no. Elective CS for breech, no. And placental abruption, no. It is definitely not category 1. And look at option L, which says category 3, previous CS, mild contractions, no labor. So I will go in for this one because she is definitely started into an early latent phase because she's 2 centimeter dilated, irregular contractions, but she's not progressing further and she's not wishing for a trial also. So my option will be that. Going into the last scenario, we have Brenda, a 29-year-old G3P2. She's in the second stage of labor and she's 40 weeks gestation. She's been pushing for 2 hours with no progress. Okay, so we'll have to take an action here. Fetal head is at +1. Ventos applied failed, and also they've attended a trial of failed forceps also. So again, multiple instrumental deliveries have been tried. Generally, we do not do a sequential trial with the instruments because we know the chances of neonatal and maternal morbidity and mortality is quite high here. CTG is showing a baseline of 145 with good variability and no deceleration. CTG is fine. So the baby is doing good, but however, we are not able to deliver the baby out. Vitals lab is normal. After consultation, a decision is made to proceed with the cesarean section. Okay, so cesarean section here, second gravida, pushing for 2 hours, failed instrumental delivery. We will have to deliver the baby quickly out. So let us go back to the options and let us look into the options here. Okay, so looking at the options. So immediate threat, no. Maternal fetal compromise, not immediate threatening, yeah. Option B can be one of the options. Now let us look into the other one. Emergency cesarean for failed instrumental delivery. That is option H. That is most appropriate here because it is a failed instrumental delivery. Okay, so though there are multiple options, we'll be choosing the most closest one here. So these are the answers. So what are the common pitfalls that we actually face in situations like this? Most important thing is you'll have to look into the scenario that's been presented to you. Look into the options, whether the options are, though they're very close, see how closely they are associated with the scenario that has been presented to you. Okay, now if you have a scenario which shows CTG with late deceleration, but the mother is stable, cervix is 5 centimeter, you can choose category 2 because there is no life-threatening situation there. Commonly, what people do, they choose category 1. No, because of the late decelerations. No, it doesn't work that way. If it is, if the decelerations are picking up, if the baseline is coming back to normal, then you see whether it is an immediate threat or whether you can wait for category 2 because category 1 cesarean sections tend to be quite traumatic to the woman. Next one, you have failed inductions, 41 plus 6, stable fetus, normal CTG. Okay. Okay, it is a failed induction, we do agree, but there is no emergency here because your CTG is absolutely normal, your baby is stable. You can choose category 3 here. Elective cesarean section scheduled for breech and primary gravida. We now starts with mild contractions. Okay, mild contractions have started. That means it's category 3. There is no rush because just because the contractions have started, you're not going to jump and do an emergency cesarean there. Cord prolapse in labor, CTG is normal, no decelerations. CTG is normal, but will you wait for a cord prolapse? No, definitely no. You will have to do a category 1 cesarean section there. Previous cesarean, not in labor, requesting a cesarean at 38 weeks. First thing, 38 weeks, you're not going to offer cesarean. You'll have to wait. You can offer her after 39 weeks, which is going to be a category 4 cesarean section. Now, category 1 means there is an immediate threat to the life of the woman or fetus. The decision to delivery interval is ideally less than 30 minutes. Category 2 means 60 to 75 minutes, maximum is 75 minutes. There is no immediate threat to the life of the mother or fetus. Category 3 means there is no emergency for you to do, but however, you'll have to do a cesarean section. That the time is quite flexible here. And category 4 is for all elective planned cesarean sections. And some examples are also given. Keep this in mind when you choose your category of cesarean section. 30 minutes, 1, 75 minutes, 2, and 3 and 4 are, there are time is quite flexible and there are no fixed time there. Thank you so much and wishing you all the very best for your exams.